my voice manages to finish the whole talk. So we're going to talk about sex matters in diabetes. And my job is to convince you that it really matters for women in type 2 diabetes. So let's get started. So I'm showing you this construct, as you can see. And the question is type 2 diabetes different in women? So this diagram is really showing the lifelong impact and interaction between sex and gender, and I'll explain the difference, on the development and outcomes of type 2 diabetes. On the top part of the diagram, you can see social conditions, and on the bottom part, you can see biological factors, principally sex hormones and the expression of sex-specific genes and comorbid conditions. And all of these factors influence the development of germ cells, fetal programming, the newborn girl, puberty, reproductive age, aging, and type 2 diabetes progression and complications. So this is just a construct, and I want to just explain to you why I'm differentiating between sex and gender. So remember, sex, we're talking about the biological sex, right? We're talking about the sex chromosomes and the expression of the sex hormones. It's an important modifier of both the physiology and disease via genetic, epigenetic, and hormonal regulations. But we must consider gender. So gender is a social construct, okay? And here it's slightly different. The differences arise from socio-cultural processes, such as different behaviors, lifestyles, smoking, perceived stress, and all of these modulate the expression of the biological sex. And all of this results, therefore, in, on the left-hand side, disease pathophysiology, manifestations, response to treatment, but on the right-hand side, the gender constructs and society will influence help-seeking behavior, use of healthcare, therapeutic response, and disease perception. And the reason I'm showing you these two slides from the beginning is for you to take into account it's not just about the sex hormones, it's not just about the sex chromosomes, it's about the social constructs as well. This also influences why sex matters and why type 2 diabetes is different in women. So with that brief introduction, I'm going to go into a little bit of epidemiology, okay? Firstly, the prevalence of type 2 diabetes in men and women. So this is data in India. This is the NCD monitoring survey in 2022. And here the overall prevalence of diabetes, and I'm sure you're well aware of these numbers, 9.3%, and impaired fasting blood sugar, 24.5% respectively. And if we look at the data in Mexico, we're not that far behind. This is data in 2012 up to 2022, and diagnosed diabetes 18%, and we can see there's a preponderance in women. 20% of women in Mexico have type 2 diabetes. So the data is quite similar. But if we turn our attention specifically to the India data, looking at the differences in men and women, and if you look on this graph, we have in blue normal fasting blood sugar, impaired fasting blood sugar in yellow, newly diagnosed diabetes in a darker blue, and then previously diagnosed diabetes in orange. On the left-hand side, urban and rural differences, which we would expect, but I want to draw your attention to the differences in men and women. So if we look at previously diagnosed diabetes and newly diagnosed diabetes, in the younger age groups and in middle-aged, we're finding a predominance in women. In the older age groups, they're really quite similar. So in younger people in India, women seem to be more preferentially affected by type 2 diabetes. If we look specifically at differences, We know the prevalence is increasing in both sexes. But women, as I've mentioned, have a higher rate in youth, men after middle age. But we also find that men are usually diagnosed at a younger age and at a lower body mass index than women. And if we look at the graph at the bottom, this is showing the differences between Europe and the Middle East and North Africa as low and middle income country examples. And I thought it was interesting. So here we've got women in the light blue and then a darker blue for men in each of the two categories. And you can see again that in Europe, the prevalence of diabetes in women tends to be lower than men during middle age, but higher maybe at older ages. But if we look at the Middle East and North Africa, the prevalence in women is higher than in men. And this is reflecting the data I've shown you from Mexico and also India. So again, low middle income countries, women are going to be more preferentially affected. So that's epidemiology. Let's now talk about sex-specific pathophysiology of type 2 diabetes. And I'm going to look a little bit at pancreatic islet cell biology. So I've shown you some differences looking specifically at gender and sex. We've looked at the epidemiology, but what happens in the beta cell and the pancreas itself? So this is an analysis looking at islets of donors with and without diabetes. And what they found when they looked at the sex differences, if you look, the female islets exhibited higher mitochondrial respiration and stronger, more robust function. They had a greater preservation of insulin content, fewer defects in islet function, and a greater proportion of alpha cells compared to the male islets with type 2 diabetes. So the conclusions in this study was that female islets tend to be more resilient in the context of type 2 diabetes, and they show distinct metabolic mitochondrial dysfunction compared to male islets. So the message from this study is that we see differences in sex in the type 2 diabetes islets, and we need more mechanistic studies to better inform if this really affects the therapeutic strategies we would use to manage type 2 diabetes. And if we look specifically at the sex differences in pancreatic islet biology, in this diagram I'm showing you in men, normoglycemic men and normoglycemic women, there's differences from there. We can see that women have a greater insulin secretion during the oral glucose tolerance test, and they also tend to have an increased glucose-stimulated insulin sensitivity from isolated islets. So as a result, when we have women with diabetes, they tend to have lower fasting plasma glucose, but higher postprandial levels. They present with more impaired glucose tolerance than men. Men, on the other hand, tend to present with type 2 diabetes with more impaired fasting glucose. So we have that difference from the beginning. And if we look also, what I found interesting is that in utero as well, maternal hyperglycemia can program your offspring's susceptibility to diabetes. And studies in male mice who are offspring of female diabetic mice, we're finding that if they're exposed to higher fat diets, the mother is exposed to this higher, richer diet, they show impaired insulin secretion. So we're also seeing this influence in the next generation. So I've shown you there's differences in pancreatic islet biology, and this particular study I liked a lot because they were looking even further. They were seeing what is the influence of type 2 related genes, a parental history of diabetes and obesity on subsequent development of type 2 diabetes. They looked at patients who started early onset type 2 diabetes and then late onset type 2 diabetes. So on the left-hand side of the graph, you're seeing the early onset patients, male and female, and you can see the influence of parental history, specific genes, and adjusted body mass index. And in these early onset patients, it's not surprising, genes had a greater effect, but more so in men than in women. And the genes involved in insulin production had a greater influence in men. And genes involved in peripheral insulin resistance had a greater influence in women. The parental history influences were similar between men and women, but there was a unilateral genetic influence of the mother being much greater in males than female offspring. If we look at late onset type 2 diabetes, those are the two bars on the right-hand side of the graph. Here, it's the influence of obesity that seems to be more important. So I thought this data was interesting, firstly because we're seeing a difference, because a sex-specific effect, but we're also seeing this effect of genetics and parental history being so much more important in early onset disease. And I think this is relevant both for India and also Mexico, where the numbers of patients starting type 2 diabetes under the age of 45 is increasing dramatically. So that's all I'm going to say about pancreatic biology and then the genetics. Let's go and look into risk factors. So this is looking specifically at biological risk factors and the differences. Doesn't surprise you, as body mass index increases, risk of type 2 diabetes increases, but this association is much stronger in women. And this is because women are more prone to body weight changes during their life. We've seen the hormonal changes, and we know that different during puberty, during menopause, and also the postpartum period. And in fact, a body mass index of 35, the relative risk of diabetes increases 60-fold in women and only 40-fold in men. So body mass index is very important. But let's now turn our attention to body fat distribution, because we know this will also influence. In the premenopause period, women accumulate more gluteofemoral fat, the gynecoid shape. It's a safe reservoir for excess energy and releasing beneficial adipokines. They also have greater amounts of brown adipose tissue. But in the postmenopause, fat distribution changes. As insulin resistance becomes more prevalent, we get a more android shape and we have increased cardiometabolic risk. Ectopic fat accumulation also increases. Healthy women tend to have higher amounts of intramyocellular fat in leg muscles and lower visceral adiposity. But as we get a deterioration in glucose tolerance, this ectopic fat accumulation increases, and this difference due to sex disappears. So body fat distribution is also important. And I've summarized some of these biological factors here. I've already mentioned some of these. Body mass index. The SWAN study showed us that women who transitioned to the menopause had an increase in their visceral adipose tissue of at least 8%. Metabolic risk factors are also different. If we look at the metabolic syndrome in women, there's more clustering of hypertension and adiposity, whereas in men, it's more low HDL and higher uric acid levels. And I've already shown you the differences of impaired fasting glucose being more prevalent in men and impaired glucose tolerance in women. Let's now look at specific situations in women. The menopause, I don't have time to go through all the changes, but remember, estrogen is protective. It's protective because it increases insulin sensitivity and glucose-stimulated insulin secretion and reduces beta cell apoptosis. And Claire has already mentioned that at the menopause, it's either aging itself that is influencing or ovarian aging. Both of these together increase the risk of type 2 diabetes development. And the mechanisms I'm showing on the right-hand side, some characteristics are important. We know during the menopause, there's a decline in estrogen production, and androgen production declines to a lower rate, resulting in an imbalance, a relative androgen excess, and a decrease in sex hormone binding globulin, and this also contributes to increased insulin resistance. And because of this increased insulin resistance, there's an increased risk of type 2 diabetes and cardiovascular disease. So the SWAN study again showed that lower estrogen concentrations resulted in a 47% higher risk of type 2 diabetes during the menopausal transition. So the menopausal transition is a time when women, we have to be particularly vigilant for the appearance of type 2 diabetes. I mentioned cardiovascular disease. I'm just briefly showing this slide because there's controversy of why is there an increased cardiovascular disease risk in women with type 2 diabetes after the menopause. Is it the hormonal changes because of the menopause, or is it chronological aging which is more important? I think this graph shows us very clearly both are important, but with ovarian aging you can see there's a clear inflection point exactly after menopause. So after menopause, diabetes risk and cardiovascular risk increase dramatically. Age of menopause is very important. In this Korean study, premature menopause, as you can see in the graphs, results in an increased risk of developing type 2 diabetes. We can also see that there are other menopause factors associated with increased diabetes risk. Age of menopause, I've already mentioned, presence of vasomotor symptoms, non-use of hormone replacement therapy. If you have fewer reproductive years, so a shorter reproductive lifespan is also a risk factor. And surgical menopause also increases the risk of type 2 diabetes. Effect of HRT, we know giving menopausal hormone replacement therapy reduces the incidence of type 2 diabetes by 30%. And this reduction is independent of body weight and waist circumference. So it seems that, replacing the hormones, we're going to directly improve insulin sensitivity in the peripheral tissues. And I'm not going to go into whether oral estrogens or combination is better, but frankly, we should be using progesterones that are more neutral for glucose metabolism when we give HRT. Finally, let's look at gestational diabetes. And again, I'm bringing this up because it's so relevant in India. Here, we know that 27% of the total gestational diabetes cases worldwide come from India alone. And if we look at this study in Canada, which is quite old now, diabetes developed within 9 years after the index pregnancy in about 20% of the women with previous gestational diabetes. Gestational diabetes, remember, signals women who have a defect in beta cell function and in whom insulin secretion does not increase adequately in response to the insulin resistant state. Gestational diabetes will increase the risks not only of diabetes, but also cardiovascular disease later in life. In this graphs, you can see the risks for type 2 diabetes. This is really looking at the risk of future comorbid conditions after gestational diabetes. So we can see here in the top left-hand side, this is the risk in control, women with gestational diabetes who had good glycemic control and women who had poor glycemic control. And you can see, obviously, the women who had poorer glycemic control have a greater risk of type 2 diabetes, a greater risk of obesity over time, hypertension, and dyslipidemia. So these are the hormonal factors. Just to mention, PCOS also gives you a 4-fold higher risk of type 2 diabetes as well. And finally, psychosocial factors. I mentioned gender as a construct has to be considered when we think about the risk for type 2 diabetes in women compared with men. Women who have no leisure time physical activity increase risk. Women who have shift work increase risk. Women who have low decision latitude. So if we have women who don't have any kind of autonomy in their workplace, they have an increased risk of diabetes. Women with lower education, increased risk. And socioeconomic levels also influence the prevalence of diabetes in women. So we must take all of this into account. This is just a summary of everything I've just mentioned. And let's quickly go on to complications. We can see there is a difference in macrovascular risk in women. Women have earlier, greater, and more prolonged deterioration of cardiovascular risk factors.
In view of the time.
Yeah, I'll be very quick now. So we know there's an increase within gender risk, and women have 27% higher risk of stroke, 44% higher risk of coronary heart disease, and a greater risk of heart failure progression. This is just really saying part of the risk is biological factors, psychological and socioeconomic factors, but remember, we tend to undertreat cardiovascular risk factors in women. In the CVOTs, there was a lower use of statins, aspirin, beta blockers, despite a higher prevalence of stroke and heart failure. Microvascular complications, it's not so clear. We know retinopathy, there isn't much difference. There is increased neuropathic pain in women and increased relative risk of non-albuminuric renal failure in women, but there are other risks as well, increased risk of depression and anxiety. What about the response to therapy? There's a lot of under-research here. We know that SUs have a greater effect in leaner men. We know as well that SGLT2 inhibitors equal benefit in both sexes, but lower prescription rate in women. And GLP-1 agonists increase weight loss in women, but the same benefit for MACE. But the overarching message here, there's greater adherence in women and also under treatment in women with type 2 diabetes. So I'll just skip this, but I want to highlight that women have the double burden, right? They have diabetes and they will also have to be caregivers as their role. So this significantly undermines their overall health. And finally, the socioeconomic barriers. Accessing healthcare is a challenge for women in low middle income countries, and cultural factors also limit women's access to healthy lifestyle and care. So I'll finish there. My reflections and conclusions. Most current medical guidelines and protocols are not gender specific. In fact, they don't take it into account. Data from one sex is used as the norm for both diagnosis and treatment for particular diseases. We need to take some of these aspects into account when we think about guidelines. Medical curriculum doesn't incorporate any sex-based physiology and pathology, and research is lacking. What I showed you is all that I could find about sex-specific differences. And my final slide, we need doctors to consider different diagnostic and therapeutic approaches in men versus women. Health systems should move towards improved preconception planning to increase awareness and prevention, in particular of gestational diabetes, and provide optimum management for women with pre-existing diabetes. And finally, for girls and women with diabetes, we must empower them to prioritize their health. This is where the gender aspect comes in, the psychosociocultural factors that sometimes we don't address. Sex and gender are the foundation of precision medicine. They should inform decision-making to promote gender equity in diabetes management. Thank you for your attention. Sorry that I was a little bit longer. Thank you.